So next topic is organ donation. It's V24. A 35-year-old man is assaulted with a blunt instrument and sustains isolated head injuries. He undergoes a decompressive craniectomy for large extradural hematoma and is admitted to intensive care unit for neurointensive care. He is orally intubated, sedated with propofol and alfentanil. Following 2 weeks of therapy with sedation being stopped for 1 week, the CT showing extensive ischemic changes. He shows no sign of neurological recovery. His pupils react slowly to light and he breathes spontaneously with some assistant. His blood pressure is unspotted and stable, and EEG does not demonstrate any seizure activity. Following discussion with his next of kin, his plans are made for withdrawal of life-sustaining therapies and do not attempt cardiopulmonary resuscitation. Order is made. What is accepted definition of the death? The irreversible loss of consciousness combined with irreversible inability to breathe. This diagnosis can be made based on neurological or circulatory death. Can death be confirmed in this patient using criteria for the neurological criteria for brainstem death? No. His pupils are reacting and he is breathing spontaneously. This demonstrates that there is some brainstem activity. Therefore, by definition, he cannot be dead based on the neurological criteria for brainstem death. Is this patient suitable for organ donation? Yes. In this instance, as his intubated treatment is being withdrawn in a planned manner, following circulatory death, this patient should be eligible for organ donation. To be donor following cardiac death. A referral to the organ donation team should be made and communication around this matter should be directed by the specialist nurse for organ donation. What are the legal ramifications of death and organ donation in this context? As this is an unnatural and unlawful death, the coroner should be informed. The coroner will liaise with the senior investigation police officer and will make a decision on whether post-mortem examination of the body is needed. The coroner does not give assent for organ donation. He or she will not object. Coroners are independent judicial officers. Individual coroners will have different procedures to follow. The patient was not on the organ donor register. Does this preclude him from being an organ donor? No. Discussion with the family directed by the specialist nurse for organ donation will explore the patient's last known wishes, and nowadays it's only opt out. Only the patient who have decided not to be potential donor, they are excluded. Rest all are considered that they are organ donor. The family gave their assent for organ donation and say that this patient was in favor of being an organ donor. There are no contraindication. The intensive care team predict that the patient will die within an hour of life-sustaining therapy is withdrawn. Should withdrawal of life-sustaining therapies be undertaken immediately? No. Even though the patient has been accepted to be an organ donor, it will take some time for the further investigation, the retrieval team to mobilize, and the recipients to be called to their transplant centers. Until all the parties are ready, the patient should continue to receive life-sustaining therapies and be optimized as far as possible for high-quality organs. What are the principles of donor optimization? Ongoing nutritional support, hydration, bronchoscopy, lung protective ventilation. Medications such as methylprednisolone may be requested by transplant team. If the patient requires vasopressin therapy, the vasopressin is preferred to be noradrenaline. Following 24 hours, the teams have mobilized and it is time for withdrawal of the life-sustaining therapy. The patient has been accepted for kidney, lung, liver and pancreas donation. The patient is extubated to air and after 20 minutes, he has flat trace on the arterial line. There are occasional ventricular complexes on the ECG. How will death be diagnosed? An observation of mechanical asystole for 5 minutes is requested. 5 minutes, the flat arterial line should be observed. Electrical activity may continue during this time. The absence of respiratory effort for 5 minutes is noted. Following this, the pupils are examined for loss of light reflection and the lack of corneal reflection. It is at this point that death is diagnosed. So first heart is asystole, then respiratory 5 minutes, no effort, then check the pupil, loss of light, then the corneal reflex all are gone. Now it's time to label the death. As the patient is to be lung donor, should patient be reintubated? Yes. This is to protect the donor lungs from contamination from stomach contents. This will be directed by the specialist nurse for organ donation. The patient should be reintubated with a cuffed oral endotracheal tube. However, ventilation should not be restarted as this risks inadvertently restarting cardiac contractions. Should a recruitment maneuver be required to facilitate the lung donation, then this should be single maneuver that is carried out 10 minutes following death. What is meant by the term warm ischemic time and why is it important for expediency in transferring the donor to theatre? Following cardiac death, blood flow to the organs will cease. However, while the body temperature is maintained, some metabolic activity of the tissues will continue. The warm ischemic time is the time from cardiac death until the body or the donor organ is cooled. A long warm ischemic time is associated with worse outcome for recipients, so this time should be as short as possible. Minimizing this time is done by transferring the patient to the theatre as quickly as possible. In some centers, withdrawal of life-sustaining therapies may be carried out in theatre environment. Thank you.